The name of this lecture is Gynecologic and Pregnancy-Related Infections. This is an interdisciplinary lecture given by myself and Drs. Hillard and Andelin. Here's our contact information. Let's get started. Learning objectives. In order to diagnose, explain, and treat bacterial vaginosis and all of these other conditions, you should be able to do the following. Describe the clinical presentation, diagnostic features, epidemiology, and complications. Describe the pathogenesis, morphologic features, laboratory findings, and key characteristics of infecting organisms, including associated virulence factors. Describe the recommended treatment, mechanism of action of the treatment, and significant side effects.
In our first clinical scenario, you are a primary care provider and have a 26-year-old female who presents to your office with 1 week of vaginal discharge. The patient is sexually active in a monogamous relationship. She reports that her discharge smells bad, reports it is fishy. Her discharge is thin and white, and she has no associated vaginal irritation or itching. On your exam, she has normal external genitalia, but you do note a small amount of thin white discharge coming from her vagina. On your speculum exam, her cervix appears normal, however, there is a moderate amount of the thin white discharge present. As we consider the differential diagnosis for vaginal discharge, the first thing that should come to mind would be bacterial vaginosis, candida, trichomonas, gonorrhea, and chlamydia. To help narrow that differential diagnosis, we would utilize a wet mount of the vaginal discharge, pH of the vaginal discharge, and a PCR test looking for gonorrhea and chlamydia and potentially trichomonas. You may also see the term NAAT, which stands for Nucleic Acid Amplification Test. PCR, or polymerase chain reaction, is a type of nucleic acid amplification test. Most commonly, you will just see PCR. Gonorrhea and chlamydia PCR are ordered together on either endocervical swab, vaginal swab, or urine. Trichomonas PCR is best done on a vaginal swab, but can also be done on the first voided urine. Don't forget to always check a pregnancy test when evaluating gynecologic complaints, as our treatment may need to be altered in pregnancy. For this patient, we obtain a swab of vaginal discharge and place it on a slide. We apply saline to the slide to create a saline wet mount. When we look under the microscope, we see vaginal epithelial cells covered with bacteria obscuring the borders. These are called clue cells. Compare this to, on the left, normal epithelial cells with normal vaginal bacteria present. Additionally, we can place a swab of vaginal discharge on a slide and drop some potassium hydroxide onto the discharge. This is called a potassium hydroxide whiff test. In our patient's case, it lets off an unpleasant fish-like odor. We also note that the pH of the vaginal discharge is elevated, greater than 4.5. Our first case is consistent with bacterial vaginosis. You can see diagrammed in this graph 3 common causes of vaginitis or vaginosis. Note that one of these causes is bacterial, one is fungal, and one is parasitic. Our patient had a thin, white discharge that smelled fishy. Her vaginal pH was elevated. She had a positive potassium hydroxide whiff test, and on saline wet mount, there were clue cells. The diagnosis of bacterial vaginosis is often made using what is known as AMSL criteria, in which at least 3 of the 4 following findings must be present. A homogeneous, thin, grayish-white discharge is present. Sometimes you will hear of the discharge as being referred to as off-white. Vaginal pH greater than 4.5. A positive whiff test, sometimes also referred to as a whiff amine test, and clue cells present on saline wet mount.
Bacterial vaginosis is the #1 cause of vaginal discharge in women of childbearing age and essentially represents an overgrowth of mainly anaerobic bacteria, which replace the normal bacterial flora. Although bacterial vaginosis is not considered a sexually transmitted disease, it is strongly associated with increased sexual activity and concomitant sexually transmitted infections. And it is really these 2 associations that you should know. Concomitant sexually transmitted infections include HIV, gonorrhea, chlamydia, herpes simplex virus, trichomonas, and human papillomavirus. Other risk factors for bacterial vaginosis include douching, which is a process where the vagina is rinsed with vinegar or an antiseptic solution. Smoking also has a slightly anti-estrogenic effect, which can also predispose to changes in vaginal flora and bacterial vaginosis. Bacterial vaginosis is seen most prominently in minority populations, especially African American and Mexican American populations. Although this is the case, it is unclear if this association is due to behavioral, genetic, or other factors. Now, the normal vaginal flora consists predominantly of lactobacilli, which can be seen here associated with this squamous cell. Lactobacilli are aerotolerant anaerobic gram-negative bacilli, which predominate in the vagina shortly after the onset of menses. Lactobacilli not only create lactic acid and hydrogen peroxide, lowering the pH, but also thrive in lower pH environments, unlike other bacteria. When the pH rises, such as through insertion of contraceptive devices or sexual intercourse, anaerobic coccobacilli become much more numerous, resulting in a shift in flora. These coccobacilli here cover the squamous cells in a fuzzy sheet and are referred to as clue cells. The typical microorganisms that cause bacterial vaginosis include a variety of anaerobic and facultative anaerobic coccobacilli, including Gardnerella vaginalis, Prevotella species, Atopobium vaginae, among others. Now, the most important member of this group is Gardnerella vaginalis. It is important not only because it is the most prevalent bacteria in bacterial vaginosis, but also because it appears to play a pivotal role in creating a biofilm, which allows other species to incorporate in the confluent bacterial mass. As the anaerobes and facultative anaerobes conglomerate, they create a variety of volatile malodorous amines, resulting in the characteristic fishy smell.
Student doctors, if you click on this link, this will take you to an up-to-date article where you can learn all about the treatment of bacterial vaginosis. Common organisms for bacterial vaginosis include Gardnerella vaginalis and other Gardnerella species. Common treatments include metronidazole, tinidazole, both nitroimidazole compounds, clindamycin. All three are available in PO or vaginal cream formulations. This slide depicts the mechanism of action of metronidazole, tinidazole, and clindamycin. Metronidazole and tinidazole are nitroimidazole compounds. Metronidazole is first generation, tinidazole is second generation. They inhibit DNA synthesis and DNA replication, whereas the lincosamide clindamycin inhibits 50S ribosomal activity to inhibit translation. Here is an alternative look at the mechanism of action of metronidazole and tinidazole. Both of these compounds cause DNA damage to inhibit DNA replication. Digging deeper into nitroimidazole compounds' mechanism of action, these compounds are delivered as a prodrug that is acted upon by nitroreductase in the bacteria to convert it to its active metabolite, which is cytotoxic. This compound then binds to DNA after diffusing into the organism to inhibit protein synthesis. And it does this by causing a loss of helical DNA structure. It also causes strand breakage, and that inhibits protein synthesis by interacting with DNA. These compounds cause cell death in susceptible organisms to include obligate anaerobes, protozoans. Pertinent to this lecture would be Trichomonas. Digging a little deeper into the mechanism of action of metronidazole, it includes the formation of free radicals, which, as you can see here, cause damage to DNA, depletion of thiols, and form adducts with proteins. There are certain undesirable side effects of nitroimidazole compounds, including metronidazole and tinidazole. Specifically, a disulfiram-like reaction when patients consume alcohol, to include flushing, vomiting, and headache. There are CNS disturbances that manifest in seizures, ataxia, and dizziness, as well as general symptoms, nausea, anorexia, bloating, and cramping. Pharmacokinetic properties of nitroimidazole compounds both come in PO or IV formulations. Both penetrate well into tissues and abscesses, as well as empyemas and cerebrospinal fluid. Metabolism is through glucuronidation, whereas the majority of the drug is eliminated unchanged in the urine. Let's talk about one of the lincosamides, clindamycin to be specific. Here is the structure of clindamycin. Clindamycin is used as an alternative antibiotic for patients who are allergic to penicillin. Clindamycin covers most gram-positives and most anaerobes. It's also effective against beta-lactamase producing bacteria, to include group A Streptococcus, which causes strep throat. It's efficacious in the treatment of toxic shock syndrome and also to decrease the risk of premature births in women with bacterial vaginosis when compared with nitroimidazoles. Clindamycin is also used in the treatment of pelvic inflammatory disease and can also be useful in the treatment of MRSA. To more broadly review the mechanism of action of clindamycin, clindamycin is a lincosamide that inhibits protein synthesis by binding to 50S ribosomal subunit of bacteria. This strategy of antibiotic function works because bacterial ribosomes are structurally distinct from human ribosomes. Clindamycin, again, binds to the bacterial 50S subunit to inhibit peptide chain elongation, also known as transpeptidation. And you can see that in the figure here. Clindamycin, as well as erythromycin, bind to and inhibit the 50S ribosomal subunit, whereas gentamicin and tetracycline bind to and inhibit the 30S ribosomal subunit. There is good coverage of gram-positive bacteria and most anaerobes. One high-yield adverse effect of clindamycin includes pseudomembranous colitis, or C. diff. Turns out C. diff is resistant to clindamycin, and that leads to overgrowth, which leads to excessive toxin release. Clindamycin does not penetrate the cerebrospinal fluid. However, it is actively transported to abscesses, and this can be a benefit when you're treating patients with abscesses.
Let's adjust the scenario slightly, and now we have a 45-year-old female with 3 days of vaginal discharge. She is sexually active, but she also reports that she recently had antibiotics for a urinary tract infection. Her vaginal discharge is thick, white, and appears like cottage cheese. She does have associated vaginal irritation with itchiness and a sense of inflammation. On our exam, we find that her external genitalia and vagina have erythema with edema. On speculum exam, we find a thick, white, cottage cheese-like discharge. The cervix, however, has no erythema. We will begin our workup with a wet mount and vaginal pH. In this case, there are no signs of cervicitis, and we would not necessarily need to check PCR for gonorrhea and chlamydia. We should, however, remember to check a pregnancy test. In this case, we are suspicious of candidiasis based on the clinical presentation. To better assess candida on wet mount, we should use potassium hydroxide. The potassium hydroxide breaks down the epithelial cells, making fungal elements more visible. However, fungal elements often can be seen on saline wet mount as well. Here we can see fungal elements including pseudohyphae and budding. As a separate test, we check the pH of the vaginal secretion and find that it is 4.0, normal range for vaginal secretions. This case is consistent with vulvovaginal candidiasis. Again, as we review this graph, we can differentiate features pointing to candidiasis. The patient complained of itchiness and discomfort and had a thick discharge. The discharge was white and cottage cheese-like. There were signs of inflammation and erythema on exam, and her vaginal pH was not elevated. We also noted fungal elements present on potassium hydroxide wet mount.
Although not as common as bacterial vaginosis, vulvovaginal candidiasis is a very common cause of vaginitis. Unlike many of the other infectious agents, candidiasis is not considered a sexually transmitted disease. One of the reasons it is so common is that there are many risk factors which predispose women to develop an infection. In diabetes, Candida can thrive in a higher glucose environment. HIV and immunosuppressive medications both decrease the immune response to infection by Candida. Often there is an added element of genetic susceptibility, especially in individuals with recurrent vulvovaginal candidiasis. Diabetes, immunosuppression, and genetic susceptibility can also predispose individuals to develop Candida infections in other locations, such as in the esophagus or in poorly cleaned skin folds in an obese individual. High estrogen states, like those seen in pregnancy and through use of estrogen therapy, increase the amount of Candida and susceptibility to infection, although the exact mechanism is still debated. Lastly, broad-spectrum antibiotics, such as fluoroquinolones like ciprofloxacin, many cephalosporins, inhibit normal bacterial flora, which favors growth of Candida species. Candida albicans causes the vast majority of vulvovaginal infections. There are some other Candida species that can cause infection, the most notable being Candida glabrata, a Candida species that has increased possibly due to selective pressure against Candida albicans by the widespread use of certain fungal drugs. Regardless of the species, the signs and symptoms of infection are very similar. Now, not all Candida colonization causes disease, and symptomatic infection is seen only with invasion of squamous cells, oftentimes after massive overgrowth. As this is the case, Candida is often picked up on Pap smear, but is considered an incidental finding unless the patient is actively showing clinical signs or symptoms of Candida infection. This Pap smear slide here shows some pseudohyphae and multiple small yeast forms in the background of benign squamous cells.
The vulvovaginal candidiasis azoles drug list is shown here. There are over-the-counter remedies and prescription remedies. Vaginal suppositories include clotrimazole, miconazole, teoconazole. Prescription vaginal suppositories include turconazole, butoconazole. I'm going to cover specifically fluconazole. The mechanism of action of antifungals is shown here. These compounds all destroy fungi like Candida albicans by inhibiting conversion of linosterol to ergosterol by the cytochrome P450 enzyme system. In the lower left-hand corner is a picture of a fungus with various organelles. To look a little bit closer at the cell wall of Candida albicans, linosterol, typically through the action of cytochrome P450, produces ergosterol, which is integrated into the cell membrane. Now, fungal cell membranes have a lot of proteins and beta-glucans and chitin outside of their cell membrane layer. That makes them very tough. So this system is disrupted by the azole compound. You can see here azoles stick to the active site of the 14-alpha demethylase, which is an obligate heterodimeric partner for the cytochrome P450 enzyme. The azole, by targeting this demethylase catalytic site, inhibits the production of ergosterol. The net effect of that is destabilization and disruption of the cell membrane. Now, fluconazole has a number of toxicities associated with it, including certain warnings and precautions during pregnancy. Because of the potential for fetal harm, diflucan and other fluconazole-containing products could cause serious and specific birth defects. Additional warnings and precautions: it turns out azoles are associated with prolongation of the QT interval, also known as torsade de poids on the electrocardiogram, twisting of the points. This QT prolongation is caused by other medicinal products such as amiodarone and can be amplified via fluconazole-mediated inhibition of the cytochrome P450 system in humans, CYP3A4. Concomitant use of fluconazole and erythromycin has the potential to increase the risk of cardiotoxicity, causing sudden heart death. This combination should be avoided at all costs. Fluconazole should also be administered with caution in patients with renal dysfunction. With respect to fluconazole, there are many drug interactions. Much of the toxicity of fluconazole and other azole antifungals are due to their metabolism. This is due to the fact that azole antifungal compounds are both substrates as well as inhibitors of CYP3A4. Concomitant use of azoles increases serum concentrations of numerous drugs, leading to potentially serious and potentially lethal drug-drug interactions. Primary route of elimination of fluconazole is renal excretion. Thus, patients who are renally impaired need to be treated with extra caution. In fact, patients with either liver or renal failure are at increased risk for these types of drug-drug interactions.
For our next variation on this case, we have a 26-year-old female who presents with 2 weeks of vaginal discharge. She is sexually active and reports 3 sexual partners this year. She has a thin, frothy, green, foul-smelling discharge. She has associated vaginal irritation and dysuria with dyspareunia, or pain with sex. Additionally, she describes vaginal bleeding after sex. Her exam shows erythema of the vulva and vagina with a malodorous, frothy, green discharge present. On speculum exam, her cervix has scattered red spots consistent with punctate hemorrhages. We will follow the same workup with wet mount and vaginal pH. However, as there are signs of cervicitis, we will add PCR for gonorrhea and chlamydia. If our saline wet mount is negative, we may also consider a PCR for Trichomonas. Again, remember the pregnancy test. On saline wet mount, we see flagellated protozoa consistent with trichomonads. We often see them as motile under the microscope. When we check the vaginal pH, we note that it is greater than 4.5, elevated. If we again reference this graph, we can identify features consistent with trichomoniasis, the disease caused by Trichomonas. Our patient had itchiness associated with her discharge. However, it is important to note that many patients with trichomoniasis actually are asymptomatic. Her discharge was frothy and green and malodorous. Also note that there can be variation in the color of the discharge. On exam, she had cervical petechia, or a strawberry cervix. Also important to note that only a minority of patients with trichomoniasis actually have the classic strawberry cervix. Her vaginal pH was elevated, and on saline wet mount we noted motile flagellated protozoa.
Trichomoniasis, which is caused by the protozoan Trichomonas vaginalis, is the most common non-viral sexually transmitted disease in females. Infection can last for months or even years. Trichomonas is associated with other sexually transmitted infections, especially HIV and human papillomavirus. Trichomonas increases the risk of HIV by causing punctate hemorrhages on the cervix, essentially eliminating the mucosal barrier. Human papillomavirus infection, of course, can lead to squamous dysplasia and ultimately carcinoma. Here we see a trichomonad on a pap smear with its typical oval shape and lancet-shaped nucleus. There is a nearby reactive squamous cell, and some inflammation is also present. Trichomonas vaginalis is a pear-shaped protozoan. You should remember that the protozoa are a type of single-celled parasites, in contrast to the helminths, or multicellular parasites. Trichomonas has several flagellae, which give it motility, and its size is roughly that of 2 red blood cells back to back. It does not appear to have a cyst form, and thus does not survive well in an external environment, and importantly, humans are its only natural host. It reproduces by binary fission, an asexual replication process in which one organism splits in half to become 2 new organisms. Trichomonas vaginalis has a predilection to involve and infect the squamous epithelium, specifically the squamous epithelium in the urogenital tract, and the organism frequently phagocytizes bacteria. Although there are other features of this organism which are diagrammed on the right, I want you to focus on the features I have outlined in the bullet points on the left.
The treatment of trichomoniasis is with metronidazole or tinidazole, both of which should be done orally. In pregnancy, you should choose metronidazole over tinidazole. Both are nitroimidazoles, again, that work by the activation of metabolites that bind to the DNA. Remember that when taking these medications, you must avoid alcohol. One key feature of treatment of trichomoniasis is the importance of treating all sexual partners to prevent reinfection. Additionally, it's important to retest patients, ideally with PCR between 2 weeks and 3 months after completing treatment.
There's a practice formative quiz in Canvas attached to this video that is linked to this learning module. You may take this quiz as many times as you wish. The questions in this quiz directly foreshadow the questions on the test for this course. Your answers on this quiz do not count towards your final grade. The rationales for the questions will appear to you after you get 4 out of 5 questions correct, and you may then progress to the subsequent learning module. Following the next learning module, you will encounter an additional quiz moving forward through this material.